course, we start off with reviewing some of the basic things you need to know if should you become an alumni of the MSFI. So what is the vision? Healthy communities enjoying quality life. So that is our purpose. If our patient feels something or patient is sick, quality of life goes down. So we want to treat them, whether symptomatic, curative, palliative, rehabilitative, preventive, just to increase and improve the quality of their lives. And of course, the mission is very long, no? But there are four. Provide health sciences integrate education. So provide humane and integral health science education. Develop and nurture God-centered healthcare providers. So this is second mission. Because we know that if it's God-centered, everything will just fall into place, no? Whether you're in practice, whether someone is watching you or not, whether you make decisions on how to charge your patients, on how to deal your patients, must be God-centered. Forge strong partnerships. Okay, so we need that. We cannot live alone. No? When you will do your practice, you need the help of your classmates here. So you need their specialty to help you out with a certain patient. And of course, it's a commitment to lifelong study. So we keep at pace with the standards. So provide education, develop God-centered, forge partnerships, and keep at pace. And of course, the core values you already memorized are faith in God, integrity, respect, and excellence. And the goal of our college, there are many colleges in the MSFI. College of Medicine is just one of them. But we want to be excellent in terms of academics, in research, so I hope you do excellent research. And of course, community service. When you start going third year, fourth year, you'll be exposed to clinical patients who may become your community. So please be good at that as well. So let's start off with membrane transporters. So the objective here is to know the relevance of membrane transporters in drug response, no, in transport of your drugs and efflux of your drugs. So, in pharmacokinetics, which you already discussed, transporters function in either absorption or elimination, right, of your drugs and even some of the xenobiotics. So this is an example of hepatic drug transporters that are represented by your, what is this shape? Sausage shape, rod shape, red ovals, it's here, red ovals. Now these are your transporters. So you could see here this drug from outside enters through the membrane. This is a hepatocyte via a transporter. The drug undergoes phase 1, phase 2 metabolism, and each of the metabolites also is excreted from the cell via a transporter. You also see here another drug, a metabolite going through your circulatory system through the membrane. Now these are some of examples. So there are many drug transporters, by the way, but the drugs that are mentioned in the slide are the ones that I will ask you because they're the ones that are common. So for example, SLC-A4, 6A4 SSRIs. What are SSRIs? Selective serotonin reuptake inhibitors. We know that serotonin plays a role in what? Your mood, no? So if you're depressed, you cannot sleep, definitely you have very low serotonin levels. So for patients who have sleep disorders, psychiatric, psychotic manifestations who are explained by very low serotonin levels, the main terminator of serotonin activity is the reuptake, right? No? So reuptake from the presynaptic cells. So we want the serotonin to be more available, so the drug there is to prevent the reuptake. So that's why you have your SSRIs. And the transporter there is a solute carrier transporter. So SLC6A4. Huntington disease is a neurodegenerative disorders. We treat them by also inhibiting the transporter VMAT2 via SLC 18A2. And of course, your sodium glucose transporters, no? Your SGLT1. So SGLT2 is the one that is for diabetes. So what does SGLT transporter do?
Yeah, the glucose transport inside.
Yeah, co-transport of glucose, reabsorption of glucose. That's why we don't see any glucose in the urine, right? If you see glucose in the urine, like +1, +2, +3, +4, that's an indication probably you're dealing with a diabetic patient, although that is not a confirmatory test. You have to do 3 things, either fasting blood sugar. What are the tests for diabetes? Fasting blood sugar, HbA1c, or you do a random test plus the symptoms of diabetes like polyuria, polyphagia, polydipsia, and your weight loss. So since we would like to remove excess glucose, we want to inhibit the SGLT2 transporter. So if your patient is diabetic and you see a lot of sugar in the urine, of course, you ask them with a medication history, ma'am, sir, what are you taking? So if he's taking SGLT2, these are your flozins, no? Very difficult first to pronounce. Empagliflozin, no? Have you heard of that? Dapagliflozin, canagliflozin, these are your SGLT2. So if they are taking that, it's expected that they still have glucose in the urine, no? Glucosuria. But if they're not taking that drug and you still have glucosuria, this is an indication maybe your glucose not yet controlled, right? For gout, no, you have lesinurad, although we don't usually use lesinurad, but it's a urate transporter 1, SLC22A2. And for cystic fibrosis, no, very common in the examination, uncommon, no, in the clinic, but cystic fibrosis has a mutation, right? CTFR gene. So the transporter there is an ABC type transporter, okay? So what happens to the transporter, no? The chloride channel becomes mutant, right? You increase chloride levels in your cystic fibrosis patients because it remains in an open state. So that's an ABC transporter. ABC, by the way, stands for ATP binding cassette, no? ATP binding cassette. SLC is solute transporters. So these are the different transporters in the pharmacokinetic pathway. So as was mentioned, it can come across and encompass your intestine, your heart, liver, brain, no, your kidneys, and even your liver. These transporters can have, they have their function in terms of transport to the circulation. Are you with me? So you have many different routes of administration, right? But the ultimate goal is to bring your drug into the plasma, right? That's why the 100% bioavailability route is what? Your intravenous, no? Intravenous. So if you give it oral, intradermal, subcutaneous, ultimately they all end up with in the blood. So you have to reach a certain level of plasma concentration, drug plasma concentration in the blood to reach a therapeutic effect. But of course, you also need transporters for excretion. That's why if you need an immediate effect of the drug, you have to give it IV. No? So that's why for patients, example, you have pneumonia, low risk, send them at home. But moderate risk, which already presents to you with tachypnea of 30, tachycardia with comorbids, you don't want to send them home because you want to reach your drug plasma concentration the soonest time possible. So tell your patient, ma'am, mas dali mag-good mas dali ang action sa atong tambal, ang epekto sa atong tambal kung ato siyang i-injection. No? Kaya kung i-oral lang naman, di na tanan absorb, no? Sa 5 ml ni mo immune, siguro mga 60% lang anak yun ang ma-absorb. Pero kani, kigahangag imong anak, mas mahigit na i-inject ang tambal, no? So you explain it, why you need to admit your patient, no? Because you need the drug right away. Now, these transporters are also responsible for resistance. So why are they resistant? There are 2 mechanisms, which are self-explanatory, by the way. So why is there resistance? Probably there's decreased uptake of the drugs, right? And these are very common among folate antagonists, nucleoside analogs, platinum complexes. What are these group of drugs? Platinum complexes, nucleoside analog, folate antagonists. These are anti-cancer drugs. That's why there are many resistant to anti-cancer drugs, right? Because of, what's the reason here? Reduced expression of influx transporters. So transporters may be influx, they may be efflux transporters. So, patient doesn't respond to your anti-cancer treatment because the patient may not express enough influx transporter specifically for your folate, for example, methotrexate, no? Or your platinum complexes. Or the other reason is maybe there is an enhanced efflux, no? So MRP, multi-drug resistance protein, that's what MRP stands for. So many antivirals, many patients become resistant to antivirals because of overexpression of your efflux transporter MRP4. What is PGP? P-glycoprotein, no? P-glycoprotein, no? Your P-glycoprotein, MDR1, ABC transporter, and BCRP as well, breast cancer resistance protein are overexpressed in your tumor cells, no? So they enhance the efflux of these drugs, rendering your patient resistant to the drug. So how do you know if your patient is resistant to the drug here in the Philippines? How do we know that? Of course, when we give the drug, the patient doesn't respond, right? That's how third world countries do it. What do you think how first world countries do it? They run genetic tests. No? Yeah, so one of the things we did in Uppsala University, in Sweden, they run genetic tests. I think I've mentioned that to you. So for cancer patients, they run genetic tests. They test for response to anti-cancer treatment. Because if the patient doesn't respond to regimen 1, they immediately resort to another. So you spare your patient from toxic effects, right? Anti-cancer treatment is very toxic. That's how they do it. No? But here, we still do not have that liberty and the money to run tests. So it's quite sad, but it's still good since we can still treat them. But hopefully, we're going there. Do you think you'll be in that generation where you run tests? You'll be in 5 years' time, no? Hopefully, no? Hopefully in your generation, no? 5 years' time, you become a physician. 7 years, 8 years, become specialists. So that's the mechanism of resistance. Next, aside from transporters involved in resistance, they're also involved in adverse drug responses. And also, it's very self-explanatory. So why are there adverse drug response? So looking at this, one of the reasons why your patient experiences the toxic effects of the drug is there may be a decreased excretion at your clearance drug. So what are organs? What are the common clearance organs? Your liver and your kidney. So you could see here, so I didn't zoom on that, but if there's decreased clearance, of course you increase the plasma concentration of the drug. So therefore, you increase the concentration increases the time of exposure of the drug to the target organ. Therefore, your patient experiences a side effect. One example is HMG-CoA reductase inhibitor. What is this drug? Statin. So these are anti-cholesterol. Very good drug. Atorvastatin, simvastatin, no? Rosuvastatin. So the first fast hepatic uptake by your statins is your solute carrier, OAT, organic anion transporter P1D1. So just remember that. No? This uptake mechanism maximizes the effect of the drug and minimizes the escape of the drug into the systemic circulation. Okay? So that's it. If you have problems with your SLC-OATP1B1, what is the most common adverse effect of statin? That's why you have to mention this to your patient on statin. It is muscle myopathy. Ma'am, kung maglain mo mga kaunuran, please come for follow-up, no? Because that's the adverse effect of your statin. Although I haven't seen one so far in my practice, but there are patients who will go into that. So there are, when you go to anti-cholesterol treatment chapter, you'll know when to stop the drug, when to decrease your dose. But that is one, skeletal muscle myopathy. And there may be a problem with your OATP1B1, where your drug escapes, no, to the systemic circulation, and then rendering your patient susceptible to the adverse effect. So that's one mechanism. The other mechanism for adverse, we're still in the adverse effect, is increased uptake or decrease in the efflux. So again, it's the same. If there's increased uptake and decreased efflux, you still increase the concentration of the drug in the plasma, increasing their exposure time to the organ. So therefore, patient experiences toxic effect. One example is your loperamide together with your quinidine. What is loperamide? Yeah, okay. So patients out over the counter, they give it, they take it for diarrhea, anti-diarrhea. What is quinidine? It's an anti-arrhythmic drug. No? So for example, you give your patient takes in loperamide, not knowing that he's also on quinidine, or you gave quinidine, not knowing you did not do a good history on loperamide intake. So what happens? Loperamide is a substrate for your P-glycoprotein in your blood-brain barrier. So it prevents accumulation of the drug in the central nervous system. But with the intake of quinidine, you inhibit the efflux of the drug, no? So therefore, you increase concentration of your loperamide in the CNS. Very bad thing to do. The patient just took loperamide and the patient went into coma, no? CNS depression. So drug-to-drug interaction is very important. What are your biguanides? Biguanides. There's only one drug under this class, biguanide.
Metformin.
It's metformin. No? Have you heard of metformin?
Yes.
Yeah, it's very good. First line of anti-diabetic treatment for patients without comorbidities, but diabetic. Diabetic but no complications rather. It's not hypertensive, no cardiac problem, no renal problem. Metformin is really a very good drug aside from it being very cheap, no? And readily available. It's even free in the centers. So it's a substrate of your SLC22A1 and A in the liver, A2 in the kidney, A3 in the skeletal muscle and the adipocytes. So they facilitate uptake, no, of the drug and develop lactic acidosis. So again, if there's increased uptake, there's problem with this SLC22 for your patient. One of the adverse effects of metformin is lactic acidosis. No? Remember that. It's also exported by your MATE transporter. So if you inhibit this MATE transporter, especially if you give metformin plus tyrosine kinase inhibitor, these are anti-inflammatory drugs, you enhance the toxicity of your metformin. The third mechanism is, of course, if there is altered transport at the target organs. So here, there's change in the transport of endogenous compounds. No? So still, the end result is that you increase concentration in the plasma. So for example, your bile acids are taken up by your ABC transporters into the bile. And then, by your OATP1B1 transporters is conjugated with glucuronic acid. So the product will be bilirubin glucuronide. Your bilirubin glucuronide will be excreted by your MRP2 transporter, excreted by MRP2, transported to the blood by MRP3, taken up again by the liver by OATP1B1. So you could just imagine if there are problems with any of these transporters, you put your patient, patient undergoes hyperbilirubinemia or cholestasis. Are you with me so far?
Yes.
So many things, no? In pharmacology so far? So many things, no? So, there's a difference between transporters and channels. Of course, when it's a channel, there's an open and closed state. The solute doesn't take any effect on the channel because it's through electrical, chemical, mechanical stimulation, right? But when you say transporter, it involves your solute, no? Because once a solute attaches to your transporter, it changes the conformation of your transporter. There's conformational change, and then you translocate that solute from one side to the other side of the membrane. And of course, this substrate, just like your enzymes actually, they also are characterized by saturability. What do you mean by saturability? They reach a saturation point, no? So that's why in many of the drugs, there's a certain milligram per kilogram per dose. There's a dose range, right? Like paracetamol for children, we compute it by 10 to 15 milligram per kilogram per dose. That's why for children, you really have to know the weights. Below that, some of your patients coming to you, Doc, siko paracetamol, wala jud na ayo akong anak. So, how much you give, ma'am? It's 2 ml, and then it's 125 milligram per 5, compute with your weight, and then you come up with an MKD of 8. Ma'am, kulang mo din mong dose. No? So, that's part of your history. When you take your history taking pediatric, patient was given paracetamol at 8 MKD. Diretso na mong 8 MKD. You may opt not to do. Patient was given 5 ml paracetamol. It has a meaning, but it's not the full meaning. Compared when you put it in your history, patient was given paracetamol at 8 MKD. So the other physicians will know na when you read your history, wala jud siya na ayo kay tungod 8 naman ang MKD. If you just put there at 5 ml, me, the other resident, will have to compute it back. No? So put it 8 MKD. Even when you order in your charts, no, you put your MKD so that the next physician, we have our own language, next resident is going to, and the consultant is going to read your order, will know that if you're in the correct range. Okay, so that's one thing you should know later. This one you already know, no? Very physiology, passive, facilitated. Okay, passive, of course, again, the difference between channels and transporters. Transporters follow certain rules of your solute, just like your concentration gradient. So passive, what do you know about passive? Down an electrochemical gradient. No, down an electrochemical gradient from high concentration to your low concentration. So high concentration here is represented by a bigger circle, then low. And facilitated, you already have another transporter that helps you with that, but still follows a downhill transport from greater to lower concentration. Okay? Yeah, that's it. It's a transporter-mediated membrane transport. How about active? In contrast to your passive, active requires energy. Why does it require energy? Because it's against electrochemical gradients. No? So, there are two types of active transport. It may be primary or it may be secondary. When you say primary active transport, it requires ATP. ATP, hydrolysis, is coupled to the solute transport. But secondary active transport, it uses the energy of the existing electrochemical gradient. So what is one example of primary active transport? Yeah, your sodium potassium ATPase, right? So one example are your ABC transporters as well, which direct one-way or unidirectional efflux of solutes across the biological membranes. So what is an example? Your sodium potassium ATPase. So the inward sodium gradient and the outward potassium gradient across your plasma membrane. Okay? The secondary transport, there are two types. There may be symport or antiport. What's the difference between the two?
Symport.
The directions. Okay? It's symport. It's a co-transporter. The driving ion is transported in the same direction with the solute. So for example, here, your driving ion is represented by your black squares. No? So the driving ion here is transported, no, from a higher to a lower concentration. At the same time, the solute of concern that we are interested in is also directed to the same direction as the driving ion, but this time it's from lower to higher concentration. So what's an example of that? It's sodium glucose transporter, your SGLT1.
Yes.
Antiport, on the other hand, when the driving ion is transported in opposite directions. So just like this one, no? The driving ion is from greater to lower, going to the right, no, in this diagram, but the solute is transported on the other direction. So example is your solute carrier transporter 8A1 sodium calcium, which transports sodium into and 1 calcium out of your cardiac ventricular myocytes. Now you have your kinetics. We will not compute, but you know your Vmax and Km, right? So when you say Vmax, it's the same with enzyme, no? Same with enzyme. Maximum transport rate. is proportional to the density of the transporters on the plasma membrane. So Vmax is the maximum transport rate. Km is the Michaelis constant. This now refers to the concentration of the substrate where the Vmax is half its value. Okay, that's K. So this is actually enzyme inhibition, but also almost the same with your transporters. So what do you remember about competitive, non-competitive, and competitive? So if it's competitive, they share a common binding site, the substrate and your inhibitor. So since they share a common binding site, there is an increase in your Km in the presence of your inhibitor. Okay? How about non-competitive? Allosteric effect on the transporter. It does not inhibit the formation of an intermediate complex of the substrate and transporter, but it can inhibit the subsequent translocation process. Uncompetitive, they can form a complex only with the presence of an intermediate complex and then inhibits translocation. Something like this, right? So you have competitive, you have non-competitive on an allosteric side, uncompetitive, no? You have now the complex, transporter solute complex. And this is a table, okay, by the way, I'll give this to you, that's effect on Km and Vmax. So if it's competitive, increase the Km, no change in the Vmax. Decrease both for your uncompetitive, no change for Km on non-competitive, and decrease for your Vmax. Okay, so let's go to the different transporters, your ABC, SLC. So by the name itself, ATP binding. So you see here, no? The binding of ATP for solute transport. So what happens here? You have here the exterior part and the interior part, and this is your plasma membrane, this is your transporter, specifically ABC transporter. So what happens here? ATP binds to the transporter, and then they open, releasing their substrate to the extracellular area. Okay? So dissociation of your hydrolysis products here will return the inward-facing conformation, okay, permitting the binding of ATP and the substrate. Okay, so that's it. So you have here ATP, you have your solute here, and then the solute is released to the exterior, then you have hydrolysis of your ATP towards ADP and inorganic phosphate. You get that? Dali lang. The other transporter is solute, no? So this one requires that the binding of different substrates, both the inbound and outbound, is mutually exclusive, no? So there's reorientation of your binding site. So what happens here? First, the substrate gains access to the binding site of your transporter, and then there's structural changes in your transporter, reopening it on the other side, then releasing it. Okay? Very easy, no? No. Now let's go to vectorial transports, no? Vectorial transport refers to an asymmetrical transport across a monolayer of your cells, no? Your epithelial and even endothelial cells of your brain capillaries. So this is involved in the absorption of nutrients, bile acids in the intestine, from the intestinal absorption of your drugs, even your hepatobiliary and urinary excretion of the drugs, and even the efflux of the drugs. So if you could see here, just like here, small intestine. So you have presence of ABC, SLC transporters. Liver, same. Kidney for secretion, and even your brain capillaries for barrier or blood-brain barrier function. What can you see here? The difference between ABC and SLC. ABC is only one direction. Look at ABC. There's only one arrowhead. They can only facilitate unidirectional flow of your solutes. But SLC can have both ways, no? So for lipophilic compounds, ABC alone can transport them, right? Because it's lipophilic. For hydrophilic cations and anions, there must be coordinated uptake and efflux transporters, like primary or secondary active transporters. So I'd like to show you a video on that, no? Do you watch YouTube in some of your
No.
lectures? No? See, let's see this. About vectorial transform.
Sabi na Samton Joyce. Can you share your thoughts, Joyce?
I nominate each to
If it doesn't work,
Class 1 Part 6, Vectorial Transfer. How will a solute move across an epithelial cell? It has to cross two membranes. This surface is attached to the basement membrane. Therefore, this is the base. Opposite to the base will be the apex or apical surface. These are the lateral surfaces. The base and the lateral surfaces together form the basolateral surface. So, do you know what separates the apical and basolateral surfaces? Tight junctions. To be absorbed, a solute must move from the intestinal lumen across the apical membrane, traverse the cytoplasm, and finally cross the basolateral membrane to enter the interstitial space. Obviously, if another solute is to be secreted, movement must be in the opposite direction. This passage of the solute across the apical and basolateral membranes in one direction is termed vectorial transport. Let's see how this works with the example of glucose absorption in the small intestine. Glucose is a large polar molecule. So, simple diffusion is not an option for passage across the membrane. Membrane transporters are required. So here, to facilitate vectorial transport, membrane transporters must be located in such a way that the ones facilitating uptake must be on the apical surface and the ones mediating efflux should be on the basolateral surface. Let's consider a scenario after a high carbohydrate meal. Here, the glucose concentration in the intestinal lumen is relatively high. Clearly, a concentration gradient exists. Therefore, the transporter has to merely facilitate the diffusion of glucose. So, among the transporters we discussed in the previous videos, which one will it be? ABC or SLC? SLC. Here, the SLC transporter is GLUT2. With continued uptake, the glucose concentration within the cell increases. A concentration gradient for glucose is established between the cytoplasm and the interstitium. So here, if a transporter is available, glucose can move along its concentration gradient. This transport can be facilitated once again by GLUT2, but this time located on the basolateral membrane. Now, did we say that SLCs mostly mediate uptake? Yes, we did. But they also mediate efflux. GLUT2 is an example. This vectorial transport of glucose is dependent on apical GLUT2 and high glucose concentrations in the lumen. But here is a catch. The expression of GLUT2 on the apical membrane is a matter of debate. Also, when glucose concentration in the lumen is low, GLUT2 is not an effective transporter of glucose. So, how then is glucose absorbed regardless of its luminal concentrations? For this, concentration gradient of another solute is utilized and glucose is transported along with it. Here, the solute is sodium ion. The SLC that co-transports sodium and glucose is sodium glucose cotransporter 1 or SGLT1. Again, glucose concentration in the cell increases. This glucose can now be transported, as seen before, through the basolateral GLUT2 to eventually enter circulation. But if sodium continues to accumulate in the cell, the electrochemical gradient for sodium will eventually be abolished. Glucose uptake can come to a halt. To prevent this, the accumulating sodium ions must be removed. However, we know that sodium is an ion with a higher extracellular concentration. So efflux must be against its electrochemical gradient. This requires energy. Do you remember the discussion of a pump that effluxes sodium against its concentration gradient? This pump, located on the basolateral membrane, is the sodium-potassium ATPase. It hydrolyzes one molecule of ATP to mediate the efflux of 3 sodium ions in exchange for 2 potassium ions. So now you can appreciate why different types of transporters and pumps are needed on the apical and basolateral surfaces of the cell membrane to facilitate vectorial transport of solutes. Please read this important note before you proceed. Here are some good to know facts. This is a summary of our discussion.
Every 3 seconds lang, no? Anyway, so very good, no? I hope these are really helpful videos, which I